I have disabled the waiting room. I don't know why it's dumping you guys all in there. So I'm gonna just have to play around with that as we go. And I'm not gonna try to get everybody in when I see them pop in. So I'm gonna toggle between that screen and this screen right here. So wait one more minute and then we will go.
Huh, no, 3 other people. I feel like that.
So welcome everyone. So it's so good to see so many faces. And as you guys know, I get super excited about reimbursement. So this makes my day. But before we get started today, it probably would be fair that I introduce myself. So get this going. So I am Amy Plano. I am the reimbursement dietitian, and I also happen to be your proud Connecticut reimbursement rep. I have served in this role for about 3 years. I'm an author, entrepreneur, private practice dietitian, foodie, self-declared fashionista, wife, and professor. And I'm passionate about helping dietitians accomplish their dream of owning and operating a profitable nutrition practice. I teach dietitians exactly how to make money using a health insurance-based payment model, so it's no surprise that I'm presenting to you guys on telehealth today. I am Connecticut born and raised, and I've been billing health insurance since 2007. So it's needless to say, I started my practice when I was an intern at Yale, and right now I run and operate a group practice in Orange, Connecticut. I also serve as a reimbursement coach to my fellow registered dietitian nutritionist colleagues. So it's fair to say I absolutely 1000% love my job. So the goal for today, the goal of today's webinar will cover the following. So we're going to chat a little bit about the current state of telehealth. So kind of talk about what's going on with the major insurances, including CMS. We're also going to talk about the billing practices for telehealth. So what we know is best and what we're seeing getting paid. And then I'm also going to summarize some of the different delivery systems that are being suggested for telehealth. But I do want to premise this talk by saying that the information provided in today's webinar is only applicable to the outpatient settings, like clinics and private practices. Billing inpatient, as you guys know, is a whole different beast. So I just want to make sure that if you are on this call today, that you understand that we're going to talk about outpatient billing. But if you're not currently practicing as an outpatient dietitian, but that's something that you want to do someday, I know we have a bunch of University of New Haven interns on the call today, which is amazing. As well as other dietitians who are new to private practice. Then I would definitely suggest sticking around, but the billing jargon that we talk about may seem a little bit overwhelming, but it's important that I want you to see the potential of all that private practice has to offer. Plus, if you stick around at the end, I have some pretty cool offers as well. So like I said, I just want to premise this and kind of just say that's what we're working with. So in terms of what has changed, so as a typical type A dietitian and self-professed control freak, it's fair to say for all of us Connecticut-based dietitians that telehealth.
Can you just document that they verbalize there's a whole system to it.
No, I get that. Okay, so hey guys, just make sure that you mute your mics. I think that might be Barb. Barb, I think we can hear you. Yeah, okay, cool. Awesome. So in terms of how telehealth has changed, it's changed completely. So the last 8 weeks for me personally have been a whirlwind. Prior to the COVID pandemic, Connecticut RDs were not able to bill insurance and get reimbursed for telehealth. So I'm here chilling like a villain on a Friday afternoon with you all doing a webinar on telehealth. So I just want to be crystal clear that even though I am your reimbursement rep and I've listened to all the webinars and I've billed for hundreds of patients for telehealth already, I am by no means an expert. Just like many of you, I'm just doing my best and staying informed. My practice, like I said, has continued to be quite busy, so I feel like I can give you a fair assessment of what's getting paid and at what level, but I am by no means claiming proficiency with telehealth by any means. So let's talk a little bit about the specific changes and what we've seen. So in addition to the fact that dietitians in Connecticut can provide telehealth, this is huge. Like I mentioned, if you're a new dietitian or a dietitian new to private practice, prior to the pandemic, we were unable to bill and get reimbursed for telehealth visits. So the fact that we can get paid is huge. I know I can only speak for my practice, but we have been jamming. Telehealth has been a true blessing, and I'm grateful every day that I can continue to do my job and have uninterrupted income from the comforts of my own home. Just for example, I had 11 patients today, and the 2 other dietitians who work for me each had 5 as well. So there is no shortage of patients out there that need our help, and telehealth has made it so much easier. The 2 main changes we've seen in terms of telehealth is documenting the place of service and the different modifiers that we are using. We're going to go specifically into each of the insurance companies in Connecticut, and we're going to look at the different modifiers as well as the place of services that we are being asked to use with the different carriers. In addition, CMS has loosened the privacy laws, and HIPAA practices have been loosened as well. Obviously, we're all doing our best to continue to operate within the bounds that we know, and we're going to talk about how to get consent and how those things have changed, but they are loosened, so this is very different than we've experienced in the past. And lastly, in terms of what has changed, cost sharing like copays have been temporarily waived by some of the insurance companies. Meaning if your service previously prompted a copay, say for example, you are a dietitian and you provide MNT for eating disorders, you would have been likely identified by certain insurance companies like Harper Pilgrim as a specialist. Right now, the insurance companies are waiving those copays and instead paying us directly. So those are the things and the changes that have mainly, that we have mainly seen change. However, with that being said, we're going wacky here. What has not changed? Okay. So lots of things have not changed from a reimbursement standpoint. Licensure rules have not changed. I coach dietitians across the country and pretty much in every state in the US. And while I know everyone was hoping for easy access to counsel across state lines, sadly, this has not changed. And while licensure rules regarding telehealth can be pretty ambiguous, they are still fully in place. Liability insurance. If you are a dietitian who is providing telehealth right now, you just want to make sure that your particular policy covers for conducting telehealth visits. You must make sure that all of your policies are current, and as well as that the fact that they do cover for telehealth. If you are a registered dietitian and you have liability insurance through Mercer or Pro Liability, who it's administered from, this general policy does in fact cover. But if you have a different policy, I would recommend calling right now your insurance agent just to make sure that you have this type of coverage. Third, verifying patients' benefits. Yep, you still have to do this. And your patients' benefits actually have not changed. They're still the same. So meaning like if your patient did not have MNT on their benefit prior to COVID, there's a good chance that things have not changed. The only thing that really has changed from a reimbursement standpoint is the way in which we deliver MNT. Okay, that's really important to know. Like I said, things have changed in terms of the codes that we use and how we bill. But like I said, the coverage and the benefits are still the same. So that means that your patients should be verifying, their benefits prior to their visits for you. And notice I said the patient, not you. Dietitians' your time is way too valuable to be chatting it up with the insurance companies. You have better things to do, like market your practice and make killer money. But don't let your patients skip out on this. And this is their opportunity to do their homework in terms of verification of benefits, not yours. So these are the things that have not changed. In terms of licensure rules, like I said, oh yes, the good old licensure map. I scratch my head every time I look at this map, and a wave of WTF floods my brain. What does this lovely map mean? Each state, as you guys know, determines its own rules regarding licensure. This is not an academy mandated thing. This is what the states say, and this is what's in place right now. So when we look at this map, obviously we have three main colors. We have the red states, the green states, and the orange states. The red states, like you guys know, means practice exclusivity. So a license is required to practice MNT or dietetics for that matter, and is subject to any types of exemptions and pop-ups as we'll go through below. Licensure of title only or certification of RDNs. That's us peeps in Connecticut. We're the green states. And this means that the state only licenses the title licensed dietitian or similar title, okay? And then title protection without formal state regulation are the orange states. This means the state restricts the use of the title to certain credentialed professionals, but no board exists, and no license is required to use this title, okay? The reason why we talk about this, obviously, in a telehealth conference on reimbursement is that if you are a dietitian who is counseling patients on the border, I know like Jackie, you're close to Mass, and I know that you have been having some issues in terms of kind of figuring out the next steps with this. So if you are a dietitian and like I said, you're on the borders of some of these states, and you have patients that maybe previously, you weren't having issues with telehealth, there's a possibility that you can. So in terms of licensure, the state where the patient is located is where the benefits reside, okay? So if your patient lives in Connecticut, obviously there are no additional requirements. The patient in Connecticut, you're good to go with telehealth. However, if you have a patient and you're not licensed in the state where the patient is located, you're likely to have to become either licensed to provide MNT to all clients or patients in that state, or two, be eligible to provide nutrition care services via telehealth in that state. So one of the things that's important, if you're a dietitian who is interested in counseling and providing and getting reimbursed for telehealth in a state that is not green, is if you were to go to this map on the Academy's website and click on this link, you can actually click on the state where the patient resides, and you can kind of answer the question, can I practice in this state? What you'll notice is that there's a link directly on the Academy's website, and it gives you a state-by-state table that will show you, the exact next steps that have to take. I believe for Massachusetts, they do have some of a reciprocal kind of relationship with us, but you still need to kind of dot your I's and cross your T's just to make sure you are following the right steps. Also, one of the things that we've seen, and the Academy has also seen, is that some states are temporarily relaxing any of the regulations in terms of providing telehealth services. So like I said, I always recommend contacting the State Department of Health, and you can actually find this link directly by clicking on the state on the telehealth map. So once again, it is not clear cut, but the reason why we are identifying this in today's talk is that I know some things have been relaxed, but certainly the ability to counsel across state borders has not. So I think it's worth having a little bit of a conversation in regards to this, as well as what the next steps to take if you are counseling patients who are non-licensure, are in licensure states. So once again, an easy way to remember this, if you're an intern on the call, or you're new to private practice, is that the rules regarding licensure are always dictated by the location of the patient. Okay, so this is important. So once again, say the patient resides in Connecticut, Connecticut's rules on licensures apply. Patient is in Massachusetts, Massachusetts rules apply. Patient moves to Florida, Florida licensure rules apply. Once again, the key part to remember about all of this is while we like to think that Connecticut is a pretty cool state, the rules regarding telehealth are dictated not by where we live, the RDNs, but where the patient resides, okay? So it's very important to kind of understand that. And if you think about it like in the sense that the patient's nutritional MNT benefits always follow the patient, okay? So that can be a little bit tricky, you know, if you guys have been, I know for myself, like I've been counseling college students, whether they be at Yale or University of New Haven or St. Joe's, and now they've moved, you know, so there's been a lot of changes that I just want you guys to be aware of. Once again, I don't know all the answers to the questions on licensure, but it's just important that we can kind of continue to do the best that we can. I think if we kind of start to do some crazy stuff and start to violate the rules, I think that creates more problems for dietitians in general. And I don't know about you guys, but I would like to see this telehealth thing stick around, you know, indefinitely after, you know, after the pandemic is over. I've been on a couple calls with the Academy, and I know that Marcia Schofield, who is the head of reimbursement and payment, is really pushing hard for this. You know, to see these benefits hopefully kind of, you know, stick around indefinitely. Once again, I don't have a crystal ball, so I can't tell you, will they be up in June? Will they be up in July? That we don't know. But like I said, if we continue to operate by the rules and do all that we can do as dietitians, I think we have a pretty good shot of, you know, of having these benefits around long term. So let's get to the nitty-gritty of telehealth. And while I'm going to provide you with the information that I'm personally aware of as it relates to telehealth in Connecticut, as all of you guys know, each insurance company has its own set of rules surrounding telehealth. So it's important that we be informed with the appropriate questions to ask when the patient's benefits are confirmed. So like I said, telehealth is an entirely different beast, especially for Connecticut dietitians. So questions that are important for our patients to ask when verifying benefits, or if you're a dietitian and like I said, you are verifying their benefits. We have to ask, what is the fee schedule for telehealth services? Given the fact that we were all provided our fee schedule in contracts likely prior to the pandemic, this information is more than likely not in our contracts. So according to Connecticut parity law, individual and group health insurance policies should in fact cover telemedicine and telenutrition services at the same basis as comparable in-person services. So like I said, you want to check with the private payers for more details. And like I said, we're finding, at least a lot of the dietitians in Connecticut are finding that depending upon how we bill, we're getting 100% payment on some of our claims, and we're not getting full payment on all of them. So I'm going to talk a little bit today about some of the workarounds that I've seen in terms of receiving full payment. But according to parity laws, which dictate how dietitians are paid in a telehealth service, we should be getting paid the same amount that we were prior to the pandemic. The second question, when calling a private insurance company, we have to know what place of service they want us to bill with. So while there's similar trends you guys are going to see today with the insurance companies defining the place of service, each insurance company, as you guys will see, has its own kind of song and dance they want us to play. The third piece is a modifier required? And if so, which one? Typically, we're seeing modifier 95 or modifier GT, although modifier GT is somewhat outdated, and I believe in 2017 they were supposed to discontinue that use. You will see today, as we go through each insurance company, that some of the insurance companies are still allowing for this code to be used. What communication technologies are allowed? So what this is directed at is that particular insurance company requiring you to use a specific platform? We're going to look at what CMS is recommending. But I know initially when this first started, Blue Cross Federal was requiring the use of Teledoc, but they weren't allowing dietitians permission to use that. We'll talk about that when we talk about Anthem and kind of the workaround for that as well. So some insurance companies are specifically requesting specific technologies that are used in order to bill for the services. And the last one, can service be provided telephonically, meaning can we use a phone? Can we just pick up the phone and call our patients? Or do we need to use some type of platform that has a video exchange? So these are the main questions that we want to be asking the private insurance companies when it comes to telehealth. So with that being said, what needs to change on the claim? So let's dive a little bit deeper and see what actually needs to change on the claim in order to bill for telehealth services. The main change that Connecticut dietitians have seen, as well as dietitians across the United States, is the place of service. The place of service defines where, and in some cases, how the visit took place. The two most common places of service that we're using right now is place of service 02, identifying the visit as telehealth, or place of service 11, which identifies the visit as an office or outpatient setting, in which we're often, in addition to that, using a modifier. In spite of the fact that it would seem somewhat obvious that we should be coding for all of our telehealth visits using place of service 02, this is not what most insurance companies are requesting us to use. In fact, in several of the cases where I've billed for place of service 02, I've actually seen a 30% reduction in my pay. So like I said, so even though it seems self-evident and that we should be using place of service 02, most insurance companies are actually asking us to use place of service 11, which you'll see in a minute when we get into the specific insurance companies. So once again, this is the main change, you know, and some, like I said, for some of us, it's not a main change because we're still using place of service outpatient or office appointments. Modifiers. So I know modifiers freak dietitians out because it's not super common for us to even use them in our general day-to-day billing. But so far, I'm only seeing 2 different modifiers being requested by the insurance companies, with the exception of Cigna that wanted us to use an obscure one in the beginning, and now they're taking 95 as well. The correct insurance modifier to use for telehealth really is going to depend on the guidelines for the insurance company you are billing. So like I said, modifier 95 is the most common modifier being used. And this is basically describing, you know, that it's an audio video MNT consult and telecommunication systems we're using. It also means modifier 95 also refers to the fact that it's done in real time and the information is not previously recorded. Modifier GT, which is an old school modifier and one that Medicare has required since as long as I've been billing, is basically, from my understanding, the same definition on some level. But in 2017, modifier 95 was put into place to actually replace modifier GT. However, as you will see with some insurance companies, some of them are allowing us to actually use this code as well.
Pickle boy.
As always, what is hey guys, I think somebody has their mic on, maybe with a dog, I think. So if you could just kill that, that would be great. So like I said, so the modifiers are going to be insurance company specific. So where does the modifier and place of service go on a CMS 1500 form? So place of service is in box 24B. And once again, dietitians billing for telehealth are more or less going to be using place of service 02 or place of service 11. Relative to modifiers, they go right next to where we put in the CPT code. And like I said, the modifiers that I've seen being accepted by the Connecticut insurance companies are modifier 95 and then modifier GT. Surprisingly, Medicare has been the most lax of all the insurance companies. They've also expedited credentialing for dietitians new to Medicare. Several of the dietitians that I coach in my coaching practices have been receiving expedited credentialing from Medicare within 48 hours of submitting their application. If you are a Medicare provider, you know that this is huge. Usually Medicare is the most complicated and convoluted to deal with. So the fact that they're the most lax and the easiest to credential with is now more or less blowing my mind. Like I mentioned, there's no change with Medicare in terms of benefits. Medicare is still just covering diabetes, renal, DSMT, and IBT for obesity when billed incident to an MD. The codes Medicare is accepted are the 97802, which is the initial visit, 97803 for the follow-ups, and we're still actually able to bill for 97804, which is the group visits. They're also allowing us to bill for additional referrals in the same calendar year using G070 and then the obvious DSMT codes. If you are billing incident to a physician, you are still allowed to bill for that service, and you are still using the same code as prior to the pandemic, which is G0447. If you're a new dietitian to private practice and you're new to billing, I don't want you to get confused with the fact when you see IBT for obesity that the Medicare benefits have changed. That's only still if you're billing incident to a physician. So once again, the benefits have not changed for Medicare beneficiaries. In terms of billing, what I have seen, and like I said, I'll open up the floor to other dietitians and see what everybody else is seeing. But from the dietitians that I work with, I've been seeing place of service. I've been seeing the most recent from the Academy and CMS requesting that we bill using place of service 11 and modifier 95. Once again, just to take a peek, that, like I said, when I send out these slides, you can see exactly where you would put those modifiers. The modes of transmission. Medicare has been pretty lax with the ways in which they're allowing us to use telehealth. But we're going to go through some of the different ways that they've approved so you guys can see what we're being what they're allowing for. So first of all, the first thing that they released is that they were allowing for non-public facing video time. So things like FaceTime, Facebook Messenger, video chat, Google Hangouts with video, Zoom, and the non-HIPAA compliant Zoom, and then Skype were the first ones that were allowed. And they've also okayed the use of non-public based text, so things like Signal, Jabber, I don't even know what those two are, to be honest with you, Facebook Messenger, Google Hangouts, iMessage, and then the WhatsApp. They're obviously also allowing for a HIPAA compliant video communication platform. So things like Skype for business, Zoom for healthcare, Google G Suites, Hangout, Cisco WebEx, which is what the Academy uses, GoToMeeting, which it looks like I have to fix the spelling on that, and then DoxyMe. I have been personally using DoxyMe. DoxyMe is free, and once you sign the BAA agreement, it becomes a HIPAA compliant platform. And like I said, it is very easy to use. In the beginning, the streaming was not great and the quality was not awesome, but I have found really good success with that. If you are a new dietitian to private practice and billing, and you heard me mention the term BAA, a business associate agreement is a legal agreement between a covered entity and a business associate. This defines the parameters for business associates' use and how they handle and protect patient health information. Okay, so it's important, like I said, that if you are counseling in a non-HIPAA compliant platform, which CMS has allowed, that you have to let your patient know the risks of counseling in that platform. So like I said, CMS has allowed things like FaceTime. They've allowed things like Google Hangouts and things that we never, ever, ever were previously allowed to use. But we do have to make our patients aware that these are not secure environments. Another option for providing telehealth are some of the dietitian-specific EMRs. So Practice Better has telehealth capabilities. Simple Practice, Healthy, and Calyx are just a couple. The big thing with these EMRs is that They are subscription-based plans, and they range anywhere from free, if you have a couple patients, all the way up to $100 per month. So just another option. Like I said, I'm a huge fan of DoxyMe. My practice does not use any of these EMRs to bill, and I have found some really great, like I said, we continue to see a normal load of patients, and DoxyMe has served us perfectly. The last big one, and huge for Medicare, as we all imagine, is that a couple weeks ago, they allowed us just to use the telephone to call and counsel our Medicare patients. Like I said, this is enormously different than what we're used to, and very relaxed, but you can just pick up the phone and call your patients. To the best of my knowledge, like I said, the only insurance companies allowing for telephonic right now is Medicare. And once again, this is a little bit ironic given the fact that we often have to jump through many hoops for Medicare. I have not seen any of the commercial payers allow for any other use aside from HIPAA compliant platforms to be used for counseling patients. So now we're going to look at some of the specifics. And like I said, this is only to the best of my knowledge. I am happy to add to this, and I am happy to. So I'm just going to talk about the different payers in Connecticut in what I have personally seen from a payment standpoint. Once again, Anthem, Connecticut, Harvard Pilgrim, Oxford, and United, I have seen all allowing for billing in a similar fashion. Obviously, the same codes, 97802, 97803, 97804. I have had the most success and 100% of all of my claims paid in full when using Place of Service 11 and Modifier 95 for all of these insurance companies. Also, they're allowing for Place of Service 11 and Modifier GT. In my experience, it seems like the insurance companies are treating Modifier GT and Modifier 95 pretty synonymously. So once again, that's what I've been seeing once again. And I think other dietitians are using other codes, but this is what I've been seeing has been paid 100%. In addition to mode of transmission, my understanding to the best of my knowledge, all of the private payers in Connecticut are still requiring us to the best of our ability to use HIPAA compliant platforms. Like I said, my big rec is DoxyMe, and I've had good success with that. Aetna, no changes in benefits. Once again, you guys know if you're billing Aetna, they are always so much fun to deal with, and they have their own set of rules in addition to telehealth rules. You guys know that they do not take Z71.3 or any other preventative codes.
Oh,
Once again, they're allowing for the same CPT codes, 97802, 97803, 97804, but once again, no Z codes. If you put a Z71.3 anywhere on your claim, they are likely to kick it back. They will not say that on the claim. They'll probably, it looks like they'll create some other reason for the rejection, but any claim I have seen in any state in the United States with that Z71.3 has almost always been kicked back. And that change happened May of 2019 with Aetna. Place of Service 11, Modifier 19. Once again, mode of transmission, HIPAA compliant to the best of your ability. And then, like I said, my rec is DoxyMe. Cigna's given us a couple different, I know a lot of dietitians, so the Connecticut dietitians were all on a small, pretty cool listserv, and we've seen a couple different things. We saw GZ, like it sounds like a rapper's name, but that was one of the modifiers they had requested that we used in the beginning. Right now, I've been billing Cigna Place of Service 11 and Modifier 95. I noticed in the beginning when I billed them, like some of the other dietitians were saying Place of Service 02, Modifier GT, my pay was curtailed by, I think it was about 30%. So like I said, it seems like the common denominator here in terms of billing is Place of Service 11, Modifier 19. Like I said, I have been pretty much using that consistently across the board and seeing full payment. Once again, I will open up the floor, once we're done, and we can kind of see if there are other other mechanisms of being paid. Once again, I always say as a private practice dietitian, keep it simple. If you know you're going to get paid in full, place of service 11, modifier 19, and you know what your contract allows for those CPT codes, there's no need to go crazy and start trying other codes. Your payment is always going to be the same, whether or not you have one ICD-10 on the claim, whether you have the 12 that's allowed. Keep it simple. And like I said, and bill with what you know is going to get paid at the maximum amount. Like I said, if we try to kind of get, creative and try some of the other codes, it's just kind of a waste of time, from a payment standpoint. So just being mindful, like I said. Once again, I have seen, with Cigna, to the best of my knowledge, mode of transmission, they are requesting HIPAA compliant. And like I said, DoxyMe has been the main one for them. If you are a new dietitian to billing, like I said, there's different ways that I work with dietitians. So if this jargon is all kind of new to you, I do offer reimbursement group coaching. I offer one-on-one coaching, and then I offer consulting services. So there's different packages that I offer. The group coaching, I have several dietetic interns in my current program, so it's a good program. If you're new to billing and this sounds like something you want to dive into, then that would be a good program for you. Right now, I am offering, for the Connecticut dietitians, I am offering some bonuses if you are interested in joining the reimbursement coaching program. I take you step by step through the process. It's a 6-month program with 8 trainings, 6 monthly Zoom calls, and then we have a private Facebook page. The goal is that I get you credentialed and I teach you the entire billing process and give you all the resources you need to get started with taking insurance in your practice. The big benefit right now for Connecticut Academy members is that if you are interested in the course, there's no payments until July of 2020. You get one 60-minute complimentary call, which is a $350 value. And if you sign up within the next 24 hours, like I said, you get these bonuses, and then you don't have to make your first payment until July. I will be starting a course on Monday, and I have 2 spots left for that spot. In terms of places to find me, like I said, I am very active within the reimbursement community, and I'm constantly trying to do my best to educate new dietitians to the field, as well as dietitians who have been here for a while. So you can follow me on Facebook at Amy Plano, the Reimbursement Dietitian. You can follow me on Pinterest at Amy Plano, the RD Boss, and I post daily tips and guidance on reimbursement_dietitian. So with that being said, I am going to open up the floor. So if you are interested in asking a question, let me unmute everybody and then we can get into some questions. Like I said, I don't know if I'll know all the answers because this is new for all of us, but I'm happy to see what I can help with. So let me go here, turn my video on. Okay, cool. So does anybody have, well, I guess what questions does everybody have right now? I see a lot of dietitians on this call. I see a lot of very proficient dietitians that have been billing for a long time. So is there any information, like I see Marianne, you're on the line, anything I missed, anything that we should add for any of the dietitians that are billing right now for telehealth? Let me see, sorry, chat. Trying to see, let me just see. And if you have a question, please feel free to unmute yourself, and then you can just kind of enter in on the conversation. I don't see any questions in the chat. Just see if I'm missing something. Let's see. Marianne Mead, no. Okay, Nicole, I have a question.
Hi, can I ask my question now?
Yeah, absolutely.
No, I didn't. Yeah, so I've been billing insurance probably in my own private practice for about 8 years now. And yes, it's all new. And I'm so excited that we are actually getting covered for telehealth. So what you're saying, I guess, to sum up for all the commercial insurance companies, you would say use place of service 11 and modifier 95.
Correct. That's what I've been seeing. That's what I've been seeing at full payment. And that's what I've seen consistent across the board. Like I said, whether or not the insurance company has identified it as the best way to bill, that's what I've seen through trial and error, and as well as across the country with most of the dietitians.
Got it. Okay, because I've been doing, I would say most of them actually been paying with place of service 2 and G2, but you're right. 1 or 2 have not been paying at 100%. So
yeah, and I find that pretty bizarre given the fact that like with the parity laws and like I said, to the best of my knowledge, like in the last 8 weeks, like I said, you know, we all have, this is such a learning curve, a good learning curve for all of us, but you know, it's just been such a big change for us. So I wish that there was something more universal that we knew would get, you know what I mean? But like I said, I saw in the beginning, like, that there should have never been a decrease, especially for place of service 02, which is identified as a telehealth setting. That's the part that I've seen that in several states with several dietitians that getting paid out the least, which to me is like fascinating. You know what I mean?
Yeah, it doesn't make sense. Yeah.
It doesn't make any sense. You know, so that's the big piece there. So that's been a surprise, but that would be a good way to summarize it. And what medium have you been using? Are you using like an EMR, or do you have anything to suggest maybe that people should try or check out from a telehealth platform?
We've been using Doxy too, and I've had great success with Doxy.
Yeah, like even my doctors, my endo uses it. So so we've had some good success with that too as well. So that's been a blessing, because when all of this happened, it was, you know, it was really scary. It was like, how are we gonna do this? And have you seen a pretty steady kind of flow with your business, or have you seen?
No, I actually thought that was interesting. Our follow-ups are pretty consistent, but we're not really getting our new evals.
Yeah.
So that's where, with the exception of like eating disorder patients, we're not getting those new inquiries.
And who are your referring docs? So who are you seeing? Like who are some of your strong bases there?
Well, and that's where I think, because I think we get a lot of docs that are like primary cares. I mean, we'll get some therapists that refer, because we definitely see quite a bit of eating disorders.
Yeah.
But I think like the primary cares, the cardiologists, like they may not be, particularly the primary cares, may not be doing too many well visits at this point. So I'm wondering if that could have something to do with it.
And have you reached out to let them know that you are doing telehealth?
That's a good point. We've been posting in quite a bit of places, but I can definitely reach out to a lot of our docs to kind of keep them in the loop and let them know.
Yeah, because that's one of the things that we did initially. Like, so I specialize in PCOS, polycystic ovarian syndrome. So a big sector of my referrals is Yale Fertility, and then all the different fertility centers, you know, down in our neck of the woods here. And they were so excited to hear that, because, you know, something like eating disorders, or when people are going through IVF, those are bariatric surgery. Those are things where, you know, they obviously require, you know, a dietitian in order to even qualify for some of these things. So they were really excited, and we may even be doing just some group stuff too as well with them, because we can bill with 97804. So, you know, so for dietitians, whose businesses are slower than they like, I mean, you know, you can run some group courses with group programs with your insurance-based patients. Once again, the payment is going to be quite low. In my experience, it's very low, but if you get, 5 to 6 patients in a typical, group, that could be a really great, it could be a nice profit center if you're running like a diabetes 6-week group program, or a weight loss 6-month, you know what I mean? So you have the capacity to see those patients in an individual environment, and then put them in a group package as well.
Exactly. Yeah.
Yeah. So that's been really kind of cool to see. And we've really picked up like the last 2 weeks. Like you said, the follow-ups were, pretty consistent. And one of the interesting things, I think some dietitians will start to see this. I'm hopeful that your patients who maybe didn't want to kind of sign up for telehealth with you in the beginning, because, we didn't know how long this was going to last. I think you'll see a lot of your patients come full circle. I'm seeing a lot of patients come out of the woodworks, patients like the practice hasn't seen in a couple of years, because everybody needs our help. I mean, I laugh, I need a dietitian's help, to keep me on track. But we've really seen like so I'm hopeful for everybody whose businesses have been slower. Like the last 2 weeks, we've gotten maybe like 8 to 12 new patients. So I think it will start to pick up for everybody, right about now. I'm hopeful. But I think the important piece in the game changer for us is just like with anything, is that we continue to tell everybody that we take insurance. It's great that the insurance companies list us in the directories, but we need to tell the doctors that we work with that we are open for business, and we're ready to see their patients. Like I said, that's always been important. And the doctors have been so excited to hear that. So I think that's important. If you have not reached out directly to the practices who were big referral sources for you, or even smaller ones, anybody, I always say any referral is a good referral. But that was really important for us. And they were really excited by that. Like the doctors that I work with, they responded like, immediately, like, oh my God, that's so amazing. And they've been sending over patients. So that's been good.
Yeah, no, that's a good, helpful piece of information. So thank you.
Yeah, no, absolutely. I always feel like we forget about as private practice dietitians, there's like nobody, you know what I mean? That's one of the trickiest parts about being in practice. Like there's nobody looking over your shoulder. And like people always say to me like, oh, it must be so fun to be your own boss. And I'm like, not really. Like I would love somebody to tell me what to do, or like, like what I should be doing or what I might be missing. But when you're, an entrepreneur and you're in your own lane, you miss so much of the stuff. So yeah, so I'm always grateful when somebody points out something to me that might be obvious, but I clearly missed.
Yes, well, thank you.
Yeah, absolutely. What other questions does everybody have? Does anybody have anything to add? I couldn't have done that good of a job, I promise. Okay.
Hi, Amy. I'm Samantha Zajac. I'm a dietetic intern with University of New Haven, and I just had a question about how the COVID pandemic is affecting like your clientele and how things are being done telehealthly, and if you think that things will be back to be able to do on-site soon, or if you would be willing to take interns telehealthly as well.
Yeah, that's a great question. Yeah, I mean, I am, and I think because I started this when I was an intern, so I started my practice in 2006 and I started taking insurance in 2007. And so it's really interesting for me, and I know a lot of dietitians on this call as well, is that we have been brick and mortar for so long that while every new dietitian's dream is to do telehealth and be remote, like I know for me, like I can't wait to get back to my office. Like this telehealth thing, I am grateful. I am blessed. I say thank you every single time I get a check from the insurance companies. But this is just not what I enjoy doing. I mean, like I said, a lot of times as an entrepreneur, like you have to pivot and you have to pivot fast. But I know for me personally, when things are safe and when things are allowed, like I will go back to my office. I think that people will be cautious. I think that, I don't foresee a decrease in business, but I foresee myself probably going back to my office when it's safe and then continuing to do telehealth. Like, I don't want to say indefinitely, but I know that a lot of people, it's like, so I haven't personally seen a decrease in business. Like I said, it's been like insane. Like today was insane. Tomorrow's insane. But I know that, but I'm also, like I said, I'm pretty vocal with what we do. And I tell people that we take insurance. So I think from what the Academy said, that they're working very hard to get a lot of these requirements for telehealth in place long term. And I think from a government standpoint, I think we're going to at least have their backing for another 6 to 8 months, I would imagine. But I personally haven't seen any changes with that. Marianne, how about you? I saw you just pop on the camera. Do you want to add anything to that? Have you seen, how has your business been in terms of all of
Well,
that?
it surprises me that I'm getting referrals.
Yeah.
That's the thing that surprises me. And I have done some contacting, and I think I have to do more. I did contact an endocrinologist that sends me a lot, and the next day I got a referral, and I called another agency that I do work for. So I've let the agencies know, like home care agencies, there's no reason why I couldn't. But unfortunately, nurses don't get covered.
Yeah.
These home care agencies are having a hard time. But
How about your EDs? You see a decent amount of EDs, and I know
yes, I do. And so the therapist, just got another referral today. So there are certain therapists that are calling constantly, and they're also coming from places like Walden too.
Yeah.
I will say I think that's the height of it. Even though I'm a diabetes educator, I'm getting some diabetes, but I can see the eating disorders is sort of taking over.
Absolutely. Absolutely. Yeah. No.
And that's hard to do. That's hard to do when it's not telehealth.
Yeah, I know. And what are
Yeah,
your
yeah.
thoughts? Are you like me where I like brick and mortar. I know change is hard, but I don't love this. I know that everybody wants to be home and
Yeah, well, I certainly like to be with people, and also I'm all alone too, so I have nobody helping me with anything. And so I'm glad I don't have as many people as I usually do, because I don't know, I'd never go to bed.
Yeah.
No.
No, that's a good point.
So, I'm at that point where I should be winding down the business, not growing it up. And here I am, just growing it up. As a matter of fact, I just got a small business loan taken care of today.
Oh, did you get the PPP one?
Yeah.
That's
So
awesome.
I'm hoping to get my staff, I'm hoping to get them, even if they have to do some things from home, I'm hoping to get them back involved.
Yeah, no, and that's been a blessing for me too with the PPP loan and with some of the other grants I hope dietitians are taking advantage of. That, I have 3 dietitians that work fairly full time, and then I have an administrative assistant who works as an employee for me. So it's been pretty cool as an independent female to be able to kind of keep these people, on staff and not have it affect them at all. That's always been really important to me in my practice. So it's been great.
Yeah, it is.
And what are your thoughts on interns? So I think Sam and I forgot.
Well, I do have some interns sitting in with me, because there were 3 of them that couldn't do their, their actual counseling experience, their outpatient counseling experience. So Georgia had asked me from UNH if I could fit them in. So I have a couple of them sitting in with some patients. And
Cool.
I tell the patient, I ask permission for the patient, as I always do it, even when they were in person. And then after we visit the patient, then the student and I will discuss it somewhat,
Sure. Yeah.
Because some of them just have had a hard time, and it would really be a help for them to be able to sit in on some of the visits.
Sure. No, I agree. Yeah, it's tough. But the cool thing with Zoom too is you can conference people in. It's just I know for me in my practice, I think sometimes things happen so quickly, and I'm sure like you, the patients are just back to back. So sometimes it's hard. It's hard enough.
It is, yeah. I'm trying to space them out so that doesn't happen.
Yeah. So then you can have teaching moments with, It's hard for dietetic interns to just, the goal is not for them to watch, it's to be able to have a dialogue. And that's one of the things that
and what
really
they get out of
hard, with this, because it's I start tomorrow at 6:30 with patients. So it's 6:37, every half an hour. So it's hard to kind of take a step back and say, what are your thoughts on that? So that's the piece that I miss. I love working with interns, and it's probably the favorite part of my job. But I found that I'm hopeful that, as we're allowed to kind of, the shelter in place is released and people feel more comfortable, then we're able to have, interns in a safe environment, whatever it is that's safe and allowable.
Mm-hmm.
Yeah. So Sam, hopefully soon, once everything kind of is allowable, then we can kind of go back to, having our interns participate in any manner that we can. Yeah.
Thank you so much, both
Absolutely.
you and Miss Marianne. Thank you.
Oh, you're welcome.
Yeah. Any other questions? Anybody want to add anything? Like I said, I tried to like summarize it. Like I said, it's all fairly new for me. It's all very new for me. Like I said,
All very new.
yeah. Like I didn't even think, I thought even though the federal government was like forcing the mandate of telehealth, I didn't think in a million years. That's never, and as somebody who enjoys a brick and mortar, like I've never really pushed hard, in Connecticut for telehealth. And I guess this was like the opportunity that's kind of just like happened for us. But I'm grateful of it, and like I said, I'm hopeful from the academy standpoint that that this will stay in place. So Nicole, why don't you jump on your mic and you tell us your question? So you have how can we bill? So tell me a little bit.
I should have asked you this before. So yeah, because I had heard with some insurance companies they were saying like 90 days, but yeah. I know you had brought this up, so I guess there's really no answer on this. Is that?
Yeah, I think, I was on a call with the academy last week, and they said that they were working pretty aggressively with all the different states to, you know what I mean? Like I said, I think that initially it was that 90 days, like Cigna had said like June something, I think if I remember in the emails, but I think as they're really realizing, you know what I mean? Like, I don't think anybody knew in the beginning what this was going to look like. And I would just say, like, continue to bill until somebody tells you otherwise.
Exactly.
And I think that means that we have an extended period of time here. Like, I think that we should all be taking advantage of it to the best of our ability. And especially if dietitians are new to private practice, like this is like, especially because you have downtime, like this is the best time to utilize that in terms of getting credentialed. Especially with Medicare, like I said, I've seen dietitians get credentialed within 48 hours with Medicare, where I've been a provider since 2007, and I can't even get them to change my EIN since December. So once again, it's just like an ironic situation with the changes. We've come really far, but so for dietitians or dietetic interns who are interested in pursuing private practice, like this is like the best time to kind of start to kind of put the wheels in motion and to really kind of think this through. I'm sure that Marianne and I both, agree. It's like if we had some downtime in the beginning of our career, like what we wouldn't have done, to really put it to use. In the world of private practice, like you don't really have downtime. I feel like, I don't know if other dietitians, I feel like I have been going a mile a minute since like the very beginning of March. Like I just adjusting and billing, and I feel like where everybody else is getting to, which I'm not complaining, everybody's watching Netflix and my patients are telling me they're so bored. I'm just like, I can't keep up. Like I'm so jealous of everybody. To take advantage of the downtime. So if you do have downtime, like, and you're a dietitian and you're like considering this, like, now, like I said, you guys know, if you follow me on Instagram, like there's never, ever, ever been a better time to be a dietitian in private practice billing insurance. Never. There's never been a better time. So this is your time to kind of rise up and do it. The best decision I made during my internship, and I never looked back. So any other questions? Okay, cool.
Thank you, Amy.
You're so welcome. And I know that a lot of you guys already knew this information. So hopefully I was able to summarize it. I will send it out.
Clarified some things.
Okay, cool. That makes me feel better because I felt bad. I was like, and so I will, like I said, I've recorded this. I will send this out, and then, oh, thanks, Cal. And then if you guys have any questions, you guys have my email. And I'm always happy to help if I can. Like I said, I don't always have all the answers, but I can certainly do my best to find the answers for you. Okay. I'll see you guys soon.
Yes.
Thank
you.
Amy.
Yeah.
Amy, it's Barbara. Can we just add that you're going to send me the list of participants? And
yeah, I got to learn how to do that because I don't know how to do that in MailChimp, but I will. Yeah.
Okay.
Yeah.
And then I'll send them an evaluation, and then I'll send them the CEU certificate.
Perfect.
All right.
All right,
Thank
guys.
you.
Thank you,
Bye-bye.
guys. Bye.